We are live from Facebook. I'm sorry, YouTube. Live on YouTube. It is 7 p.m. We are live.
Good evening, everybody. Can you hear me fine?
Loud and clear, doctor.
Thank you. It's a special evening tonight. It is my pleasure to introduce our special... it's a special evening tonight. It is my pleasure to introduce our special... it's a special evening tonight. It is my... there is... Ben, I think the problem might be on your end, Ben. There is an echo, yeah?
Yeah, no, it was coming from Joshua, Dr. Joshua. I think he's recording. I already muted him. You can start over again, doctor, for editing purposes, please.
No problem. Good evening, everybody. I am delighted with our weekly seminars that we've been doing at the University of Miami, but tonight is a very special evening. I welcome you to session number 18 today on September 17. I'm Jacques Morcos, professor and co-chair, Department of Neurosurgery and Otolaryngology, director of Cerebrovascular and Skull Base. The co-directors of this course are Carolina Benjamin, my partner, assistant professor, and director of the Keynes Dissection Lab, specializing in brain tumor and skull-base surgery. Michael Ivan, assistant professor, Department of Neurosurgery, director of Brain Tumor Initiative, who specializes in brain tumors, skull base, and epilepsy surgery, as well as my two endovascular, open vascular partners, Bobby Stark, co-director of endovascular neurosurgery, director of endovascular research, as well as Eric Peterson, associate professor and director of endovascular neurosurgery. It's been a very popular and very successful string of sessions we've been holding on skull base and cerebrovascular. Welcome to Miami. This is our center, our two main hospitals, UMH, University of Miami Hospital, and Jackson Memorial Hospital. These are the sessions we have done over the last several weeks, and several more are coming up until December. To our audience, we have audience today from multiple sources on Zoom. We have with the Neurosurgical TV channel with John Bennett, who's kind enough to broadcast. We have a special channel in China. To all our audience, if you have access to Zoom, send us questions to the Q&A box, and I'll be happy to ask our speaker and panelist to discuss. We don't offer CMEs. Please share the news of our conference in your social media. And please send me ideas you have on future topics in cerebrovascular and skull base, or speakers you would like to hear from, and I'll be happy to try to include them in our future sessions. For example, next week, we will have Nelson Oyisiku and Eduardo Velutini discussing pituitary tumors next Thursday at our usual time, which is 5 p.m. My partner, Mike Ivan, has been also spearheading a Wednesday conference, Miami Global Brain Tumor Symposium. Next Wednesday, for example, is Roger Stoop, the famous Roger Stoop with the Stoop protocol, who will discuss glioma research, new and not so new trends in clinical glioma research. Many thanks goes to our team that makes this happen: Ingrid, Roberto, Cristina, and especially Ignacio. You can connect with us through these links you can see here, through emails, on Twitter, on departmental Instagram, and so forth. Now, why is this evening special? Let me first introduce our panelists this evening. Ziad Haj from Novant Health Brain and Spine Surgery, Neurosurgery, and an endovascular neurosurgeon in Charlotte, North Carolina. His lineage goes back to our common friend, Juha Hernesniemi, and myself, to Dr. Fadi Sharbel and Sepi Emin Hanjani. Next is Adib Abla, Associate Professor at UCSF, Director of Cerebrovascular Surgical Disorders, also an open and endovascular neurosurgeon, of course, in San Francisco. And Adib's lineage goes back to the BNI with Robert Spetzler and fellowship with Mike Lawton. Again, welcome, Adib. And our third panelist, my friend of many years, Ketan Bulsara, who is professor and chief of division of neurosurgery at University of Connecticut, also a neurosurgeon and an endovascular neurosurgeon, and in Farmington, Connecticut, whose lineage date back to Duke, and of course his very special relationship with Taka Fukushima. So we've got extremely a wonderful pedigree of panelists today. But now the main course of the evening is this gentleman here, Juha Hernesniemi, who is professor and chairman of the Juha Hernesniemi International Center for Neurosurgery at the Henan Provincial People's Hospital in Zhengzhou, China. I'm going to introduce him, although he really needs no introduction. I'm just doing it for myself because I love to talk about this man. So Juha was born in a tiny village of Niimonen in Kaunas, Finland. Now, this is a village of less than 100 people. He was born in 1947, and perhaps that has something to do with the amazing simplicity with which he operates. I don't know. This is a picture, a Google picture of the village today. Amazing, peaceful, tiny place. Maybe he can tell us something about it later. Juha obtained his MD at the University of Zurich in Switzerland in 1973, and I believe this is the first time probably he was exposed to Yazergel when he was a medical student. Then became a specialist in neurosurgery, got his PhD in Helsinki in 1975. He then left for Kuopio, where he spent 17 years. And interestingly, he predicted when the chair in Helsinki asked him when he'll be back, he knew he was going to be back 17 years later. He indeed came back to Helsinki as professor and chair and spent another 17 years. And of course, this is where most of us know him from, and his international fame are mostly from those years. As if that was not enough for a career for him, he had a small stop in Peru and Indonesia in 2016, then in Nepal, working with some of his former fellows, and now since 2018, he's been recruited to be in China, and we're going to hear more about it during his talk. What can I say about Professor Hernesniemi? I can say a lot. He is a special man. He has an incredible operative experience of more than 16,000 cases, more than 6,000 aneurysms, more than 600 AVMs, dural fistulae, 3,500 brain tumors and counting, prolific writer, more than 450 articles, 200 reviews, chapters. His H index is 72. Now you can measure the impact of a man or a woman or a neurosurgeon in many different ways, but the next paragraph probably tells you the best. He's had 3,000 visitors when he was in Helsinki. He's trained more than 100 fellows. His videos, by the way, which are completely free in surgical neurology, have been viewed by 40,000 neurosurgeons. Now, mind you, there are 50,000 neurosurgeons in the world. I'm not sure where the other 10,000 are hiding, or they don't know about his videos. We need to do something about that. Recognitions, I'll just mention two simple things. He is considered to be one of 69 most prominent neurosurgeons in the last 100 years by World Neurosurgery. He is considered by Jolie magazine to be one of 18 top neurosurgeons in the world. But that's not why I personally like Juha Hernesniemi. I like him because of what's in this slide. And this is my own personal observation of the man. I've known him more than 2 decades now. I'd like to summarize what I think is quite unique about him. He is a fearless master of the economy of motion in surgery. He has an uncanny ability to tame both space and time during his surgeries. He exercises economy of words. He uses very few words, much like the surgical moves that he has, or the short selection of surgical approaches that he uses. But each word and each movement he does counts a lot more than yours or mine. He has an incredible mind's eye that can see often more than what his real eye sees. You discover this when you watch some of his videos. You wonder how can he see what he's doing? Most of us will not be able to recognize what he's doing, but he does. And that, of course, that comes with experience, that incredible depth, perception, and ability to have a very well-trained mind's eye. There is simplicity and intensity of purpose in what he wants to achieve. And that translates in how sublime his technique is and how incredibly humble he is of character. It's an incredible contrast that you don't see often in neurosurgery, or very rarely. He is a no-nonsense guy, a pure soul with almost childish innocence that leaves no room for pretense in himself or in others, meaning he just says it like it is. And if you don't say it like it is when you are in his presence, he probably will not appreciate you. And lastly, nobody is more beloved by their trainees as Juha Hernesniemi is. which is why anybody who knows him falls in love with him for what he has done for the field, for what he continues to do for the field, for the kind of human being that he is. And I'm going to stop talking now, and I'm going to stop sharing. And Juha, please share your screen, unmute your microphone, and tell us everything you want to tell us about your career and your view of neurosurgery. And thank you so much for joining us tonight. And I'm sorry, before you start, I'd like to thank very much Binju, who also is on the panel and is translating live from English to Chinese everything that is going on here. And Ben, my good friend, thank you so much for doing this. Juha, all yours.
Thank you, Jack. Thank you very much for your kind words. In neurosurgery, the past doesn't mean so much. You have to prove every day, every time, you have to prove what you have done and your experience. So in every case is important. So now I will speak about my experience in cerebral aneurysm surgery and about the feelings, how the things are going now. So this is a sentence. We continue to enjoy the perfect lip around the base of those deadly sacs. This was written in Miami. I was a fellow of Professor Pierles at Jackson Memorial Hospital more than 1 year, 92, 93. So this is a nice sentence. I base my lecture webinar on that. So like Jack was telling, so during the 18 years in Helsinki, I had extremely many visitors in Helsinki, and I learned a lot from them because we could discuss after operations, and they made their critical remarks on my techniques, and I had good ears to listen, and all the time was changing the techniques more simple and to serve the patients better. And in the operation room, we had this world map. You could put your needle where you are coming, and so at the end there was no more place in Europe, but also some crowded places in other parts of the world. So now I'm working in China since more than 2 years at the Henan Provincial People's Hospital. This is the second largest hospital in the world. The largest hospital in the world is in the same city, Zhengzhou. It is a university hospital, our rival. So once more, the perfect lip around the base of those deadly sacs. Is it over now? Like in the song, those were the days. So I will deal with this subject, because in my hospital, more than 70% of the cases have endovascular surgery. So those who are doing open microsurgery, lipping, they are called last of the Mohicans, because the tribe is getting smaller and smaller with the development in treating cerebral aneurysms. I have to give credit to my teachers. This is extremely important in neurosurgery and of course in every field, that you give credit to your teachers, because you are standing on the shoulders of those who are teaching you. You are not beginning from the same point than them, but you continue their work, and this is extremely important. So these were my teachers. This is famous photo from Chicago, 1988, taken by Mrs. Yasakil, Mrs. Diane Yasakil. You see here, Professor Yasaki is 63 years old, and Professor Drake is 68 years old. Take a look on these guys. They are like small boys studying, interested the anatomy of the human cadaver head. This is extremely important because learning curve is a lifetime. I remember when I was studying medical science in Zurich. So my teacher in anatomy, Professor Diane Dendery, he was shouting, medical study is a lifelong study, and anatomy even more. And this is extremely true. We cannot learn anatomy in our maximally 100 years of life. We should need more time to learn perfect anatomy. There's always new things there. And this is in Miami, 93, February 93. I'm sitting with Professor Drake. He's checking all the cases of the 1,767 vertebral basilar aneurysms that formed the book of London, Ontario experience. They were nice days. Professor Drake had extremely good memory. He could remember nearly every case, and then we were arguing about some complications or outcome. I could always find a patient in my computer, in my database, and then we found the track sheet, and then he corrected if he was wrong or right. And this picture is from 2003, Professor Yasakil operating on in Helsinki. It is drawn by my first Chinese fellow, Hu Shen. And take a look, all in the operation room are European, but the picture looks Chinese. So it means that we are seeing the world differently depending which culture we are coming. And this is Zurich. Zurich was the Mecca of microsurgery. All the world came to learn from Professor Yasakil and see him to work. This is 1982. I had clipped my first aneurysm in 1976, so I felt rather experienced, but my eyes were opened. I learned a lot. I saw totally different world. Professor Yasakil was like Usain Bolt or Muhammad Ali. He was number one, then there was nothing, and then some other neurosurgeons in the world. So we couldn't, of course, not discuss, you know very well how the strict it was in the operation room. But after surgery, we went to restaurant, and then we were discussing the operations. And this was very useful for us to change the experience and to learn other colleagues around the world. One afternoon or evening, Jesus Martinez, the guy on the right side from Mexico, he told, one day we will be better. We didn't believe that time, but it is certainly so. We are standing on the shoulders of our teachers, and this is the way how it happens all the time in the world. So this is Dr. Drake, Professor Drake and Professor Pieles in London, Ontario. I went there with my big luggage in 80s and didn't find neurosurgical department. So one man with the glasses, Professor Pieles, came to me and asked, can I help you? And they helped me in many ways. Without them, I wouldn't be the chairman in Helsinki. To speak about endovascular surgery, it was Serbinenko from Moscow, Burdenko Institute, who published in the mid-70s article in Journal of Neurosurgery, balloon occlusion of the cerebral aneurysms. Main part of the world was laughing, but my teacher, Dr. Leitinen, didn't do. I have also met the second big star of East, Seklov. I was sitting with him 6 to 8 hours, and he was telling his remarkable life story. So these are the great men in the beginning of the endovascular surgery. And like I mentioned, my teacher in stereotaxy, Dr. Leitinen, he didn't laugh on the Serbinenko's publication, but he went to Burdenko Institute and in 2 weeks found out how these balloons are made, came back, and called Nokia. That was that time doing rubber shoes, not cellulars. And in a few time we had these balloons, and we could make experiments in rabbits nighttime in our angio suite, occluding abdominal aorta with the balloons, and made a small publication of that. But then Dr. Laitinen had to leave Helsinki because he lost the competition on the chairmanship and professorship. So he went to Norway and Sweden, where he later made his life work. And I went to microsurgery, didn't continue in endovascular surgery. But I had connections with endovascular surgeons a lot. Here you see Guglielmi in Helsinki. Now it is 30 plus years of the first Guglielmi detachable coiling. There are few people in the world who can change the world, but Guido Guglielmi is one of them. You see Ling Feng, Professor Ling Feng, above from Beijing, China, and of course Jack Moret in Helsinki also. Jack Moret told me after seeing me to operate around 10 cases in few days of aneurysms that you may continue. So I have the license to continue. Now, here is the middle cerebral artery aneurysm, unruptured right middle cerebral artery aneurysm. In the follow-up in 2 years, it was growing slightly. There is a nipple of the aneurysm, and it was growing, and the patient came for surgery. So here you see the operation, right-sided lateral supraorbital approach, incision to the skull, one layer opening, strong hooks, retracting the flap, small flap. Only upper part of the temporal muscle is cut, and then I make one burr hole here. I was always wondering already as resident, why are you doing the burr hole down in the most difficult place? So I began to do here, and now under high magnification, opening the sylvian fissure with a needle, very cheap, and then injecting water inside the sylvian fissure. And you see these are Kamiyama schizos. I have been around the world and always take a look for the best things, tricks, instruments. Kamiyama schizos are extremely good, but also very delicate and expensive, so you will lose them. I have lost in the first moments here in China my schizos. So now going down in the sylvian fissure, which I opened distally, we see the strong wall of the aneurysm, but we see also in the upper part, we see the pleb, the thin part of the aneurysm, cutting the arachnoid under high magnification, dissecting M2 away from the aneurysm base, checking the origin, and now I should put the temporary clip. How? I go distally. I will find below the aneurysm, I will find the M1, checking the aneurysm more. And you see now, you saw now the pleb, the aneurysm would rupture there. And that's why, because of growth of this pleb, the patient came rather quickly for operative treatment. So now I'm dissecting to see the M1 below the aneurysm and saving the perforators, put the golden temporary clip on the base of the aneurysm and take a J-formed clip to take the strong base of the aneurysm and checking the position of the clip, take the temporary clip out, slowly, carefully, this is important. And then now checking the first clip position, then because the aneurysm has a strong base, I have to add more clips, one more J-form clip is going there, and then one more small clip to take, because in the handling of the clip we have a weak place, the aneurysm may fill, so this small clip was going there, and now there's small remnant here taken by one more clip, and then after that we checked with Doppler and ICG, so the M2s are well filling, and this is the situation. The patient went 3 days after surgery home, flew home, having good outcome. So this was the sister of Guido-Guglielmi. The patient was sister of Guido-Guglielmi, and I think this is very important, at least for me, because Guido-Guglielmi is the inventor of the coiling, and he's sending, in spite of that, his sister for open surgery, because wise doctors select the best treatment for the patient. Wise doctors recommend the most proper treatment for the patients, and we have to know that patients are not doctors. Patients are many times selecting the treatment modality. We should tell which one is better or not. Now I come to the point, how are we doing? This was the morning questions of my teacher, Professor Skip Peerless, in Jackson Memorial Hospital in Miami, 92, 93, always, how are we doing? I could never answer terrible. I had to say always fine, 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 like it is the habit in USA. How are we doing? Should I now answer? We are doing terrible. Why microsurgery is going down? Why are we losing our skills? There is a deep gap where the aneurysm is hiding. Then there are a lot of fears, and there's a lot of lack of skills. This is extremely important. There is poor training, love of comfort, less experience. This means that fears are coming. There's big threshold to operate on, and this is extremely important in open microsurgery. Why microsurgery is going down? Why are we losing our skills? Helsinki, during my time, 18 years, 95% had open microsurgery of the aneurysm. Only when I was traveling, they were coiled, but now, big change, only 35% of the aneurysms are clipped. This means that maybe one case a week will be operated on instead of many cases. This means a big threshold and fears in operating on, is my thinking. And why? In microsurgery, you see everything. All bleedings are caused by you, not by the fate. No black and white shadows, but the real world is seen. And complications and deaths are difficult as you see directly everything under the microscope. It was your hands and instruments at the place. So these are complications. This is Xi'an. These are terracotta soldiers in Xi'an, big army of soldiers. And these are like my complications. I've operated more than 16,000 cases, so I see here different soldiers, hemiplegic, dead, oculomotor palsy, and so on. So these are the complications. Neurosurgery is not different from sports or arts. Hard training is needed. This is very important, and the training time is long. So there is an old rule. If you have spent 10,000 10,000 hours, train something, then you will come to the world top. It's certainly true, whatever you are doing. But in neurosurgery, I have added that you have to spend 10,000 days in operation room to be at your best. And you can count how many, which age you are. It is 50, 60 years, maybe, after hard training and operating on a lot of cases. Neurosurgery is hard contact sport. As mentioned, you have many complications, difficulties. One important thing is we should not gossip. If I hear someone gossiping, I just say that I have enough own problems. If it is not very didactic thing, I don't want to hear about it. So I saw next video. This is running. Yeah. This is edited by Daniel Kochurov. He's now working in Israel. This is unruptured giant basilar artery aneurysm. 68 years old lady. Huge aneurysm. Patient is in park bench position. Make subtemporal approach with spinal needle. This one you need always when you go subtemporal, otherwise you destroy the temporal lobe. And then opening the dura, and there's some bruising in the brain, and then I go subtemporally and go to the tentorial edge and opening the basal systems here, and then you have space. Then you have space. Then you are no more compressing the temporal lobe, and then to come better to the basilar artery aneurysm base, I open the tentorium. I cut the tentorium behind trochlear nerve, coagulating first here, and then cutting, taking care not to cut to the superior cerebral artery and not to cut the trochlear nerve. And I attach those leaves with clips on the dura. Dr. Drake used the stitch. It's extremely difficult to put the stitch, so these clips are more practical, and we have also published this trick. And dissecting more, now you see under high magnification, you see the basilar artery. We made ICG here. Then I put temporary clip on the basilar artery. I think I put also on both posterior communicating arteries. Now changing the position, and then dissecting the strong aneurysm base. And there's some venous bleeding in front of the aneurysm, which I cannot manage, so it is disturbing a little bit this video. Usually the field should be very clean. And now I made a hole in the aneurysm, so it is now there's no return. There's no return. So the first clip is going on the place. And then changing the clip several times using ring clips like Dr. Drake used to do in giant aneurysms. So changing the clips, checking the situation until it is perfect. Otherwise, the patient will not survive here. So now this is coming from the hole. Changing, reapplying the clips until the clips are perfect, long enough to take the strong base. I think here now one of the clip is occluding the posterior cerebral artery, so I take it away and then add above, traveling with the clips, I call it, when you have clips too tight, so you take one out and then go upwards, and all the time this venous bleeding is disturbing. And now it's finished, and there are 2 clips on the base of the aneurysm, and checking, a lot of checking with Doppler, ICG, and you see that the PCA and supracerebral artery are open. No filling, of course, it cannot fill because you have made a hole. And then taking the clips away, putting fibrin glue in the dural bleedings, important. And then closing carefully after good hemostasis. And this is the state of the brain after surgery. And these are the post-operative controls: CT angio, CT angio, CT angio. With CT angio, we did also DSA in this case. It was rather seldom done, but in this case, special case. So this was giant basilar tip aneurysm. Can I do it again? I have done many, but the question always remains, can I do it again? Can I repeat it safely? And can someone learn it? And do you have that kind of surroundings? You can do this surgery. This is very important question nowadays. So there's huge pressure from the surroundings, from media, colleagues, lawyers to do endovascular surgery in these cases. Has some problems in training. One of the problems, or 3 of them, are time. Then you have regulations of working time, like in Europe, 37 hours a week. Then the young people need free time. They ask for quality time, family time, and the general attitude is not so positive if you are not earning a lot of money for hard working like it is needed in neurosurgery. I call those fellows who came to Helsinki hungry samurais because they're working without salary and very hard, endless hours operating on, recording and writing papers. So our career is short. This olive tree is 3,000 years in Turkey. So as compared to that, our lifetime span in neurosurgery, active time, is rather short, 50 years. So as also thinking that fishing might be better than surgery, I didn't believe that. So after my retirement, I have continued to be involved in neurosurgery. But still, I think, how can you learn, how can you teach these, to put these clips in this way? Can I do it again? Can I repeat safely? Can someone learn it? And this is difficult nowadays. There is no good answer, except there are a lot of videos which tell how to do. So you can push these coils in basilar tip aneurysm after 1 year of training in endovascular surgery, but you cannot put these clips after 1 year of training. You need many years of training to clip that kind of aneurysms. So in good microsurgery, only training makes a master. You have to eliminate the tremor. Initially, in the first months or year, you might have tremor. If it is not disappearing, it is better to do something else than microneurosurgery, endovascular surgery, neurology, or psychiatry. Continuing tremor is very stressful for the surgeon, and as everybody sees it nowadays in the video screen. You have to analyze your experience. This is extremely important. You have to have own record of your operations and results, to tell the patients how the surgery coming will be. And once more, the training time is extremely long. It is lifetime. When I was in Miami in Jackson Memorial Hospital, I applied for a professorship in the most northern neurosurgical clinics in Finland, and one of those referees who assisted us was Picard from Great Britain. He wrote this rather short comment on me. At the age of 45, this man seems to be happy to analyze surgeries of others. This meant that I was writing the book on Drake and Pierce surgeries. I learned a lot from this one, and I could forget this sentence, even it is rather pretty nasty sentence. So it is not always easy to do neurosurgery, sometimes very hard to do neurosurgery. One of the important things is, if you want to do the real microneurosurgery, open microsurgery, we should not get seduced by the money. And this is very important. If you want to earn a lot of money in neurosurgery, you should do something else than clipping of the aneurysms or try to continue. So money, money, money. Endovascular is one of the biggest businesses, and it is extremely heavy to compete with that. So at the moment, quite frankly, if open microsurgery wants to survive, you have to be good and efficient. You have to be both. Only perfect follow-up tells the truth, and this is a must. Only in Finland, in some other small countries, you have a good follow-up. You can follow up every patient until they dead. So you see the effect of your treatment. Worst or no follow-up in the largest countries of the world with the biggest economies. You cannot follow up the patients in China, Latin America, difficult in USA. You are losing 10% of your cases a year, and the same counts also many other countries. The willingness to follow up the patients long time is also many times absent. But I think in the big countries, they will open their eyes. Why? Because treatment must have good results, and it is expensive. So many times I hear in congresses, in my series, in metropoles, follow-up maybe 5 minutes, or we are waiting for the figures which never come. These are one of the things when you ask for the follow-up of the patients. So this is the series of the Finland, Helsinki and Kuopio, Kuopio and Helsinki. So there are extremely good databases in both cities. I initiated in Kuopio in 1980s. Now collected more than 18,000 aneurysm patients with more than 22,000 aneurysms. I have operated, like mentioned, more than 6,000 of them, and that we have also good databases of with all information on AVMs and dural AV fistulas. So how to do better? Extremely good follow-up is important. You should know what happens to the patients you have treated long time after the treatment. It's never too late to train hard. As mentioned, medical study is a lifelong study, and anatomy, to learn anatomy even more. You should train your best young people. They should become better than you. You have to be proud of your young trainees, young people, because they certainly continue what you have been teaching them. There are some problems in training. The personality of the trainee might not be good for a neurosurgery because attitude might be not good, not hardworking. And if the trainee is always ignoring advices, then it is not possible to train this person. From the trainee side, from the teacher side, there is many times lack of mentors, heroes, friends. We are very heavy protecting our own territory, and many times we neurosurgeons are like bunch of wolves, both in academic and the private sector. If somebody is weak, we might even kill this person. So training is lifelong. Learn to use your time, optimize your surroundings to have enough time for neurosurgery. Learn from history and surroundings. Listen to your teachers, but don't believe everything. Don't believe everything. Think how it could be done differently. If you find a better solution, then do it. Do it. So this is how to advance here. You should discuss your problems, share your troubles with somebody you trust. This is the mentor. And you should select a good mentor. You should work hard, do also unpleasant jobs well, and assist a lot of operations. And learn from others, especially nurses. Nurses have long experience and good eye for surgery. They will support you when you are doing well. And very important, cooperate well. You have to cooperate well in a team of nurses, doctors, and you have to take care of the patients. So now, as mentioned, there is heavy pressure of the surroundings, society in favor of endovascular surgery. If you want to continue direct surgery, clipping of the aneurysms, you have to be mentally extremely strong. And there are many different cultures giving pressure around the world, but you have to be extremely strong and sure about your skills and also about your results. One of the disturbing me is the shaving of the female hair. Hair is one of the oldest and worst punishing violations of females. This is very common in China and also many other countries. This favors endovascular surgery many times. You should make minimal invasive haircut. You should not do extensive skull-base approaches to clip the aneurysms. For me, even for me, they look terrible. Do it simple. This is the lateral supraorbital approach I have been using since 80s. And with my successor, Professor Niemelä, we operated in maybe close to 20 years ago, one proximal middle cerebrospinal aneurysm, when M1 aneurysm from skin to skin, 25 minutes. And we have done several of them, not the same time, but close to that. So this is very practical approach when you can, when you have learned to do it to the aneurysms. Flap should be large enough. There's a lot of discussion how small flap I can do. Flap should be large enough for your skills, for your instruments, for the lesion. Because surgery is not sports, patient is paying for that. And you should remember, not the walls, but the good team is doing the work. In this hospital, nearly diamonds on the wall, but surgery in operation room, not that level. So only stupid people still continue clipping. Who have clipping? Poor people have clipping. In China, poor people without money for endovascular surgery, they get clipping. And who have no treatment? Poor people who don't have money for a clip. This was in Nepal. The ruptured aneurysm patients went home because they didn't have the money, $300, $400 for a clip. And one of the important things is Even neurosurgeons informed that opening of the head is dangerous. This makes our own reputation questionable. To open the head is not dangerous. It is our profession. Those telling differently should not call themselves neurosurgeons, and those who are opening the head in a dangerous way should stop their activities. This is my thinking. So in microsurgery, so many times asked, what have I done? Now there is heavy control of the surroundings and society. WhatsApp is singing, Twitter is singing, WeChat in China. So there's a lot of information going on and a lot of gossiping. But one thing is sure, you cannot continue with the flow of complications and poor surgery because your reputation is going down with this information transfer. There are many routes that go to Rome. Take the shortest, cheapest, and best one. It is many times clipping, middle cerebral aneurysms, and many other aneurysms. This is from the Kuopio-Helsinki database. So 1/4 to 1/3 of the aneurysms are complex. Out of the 22,000, there are large aneurysms, 1,500, giant 600, middle cerebral aneurysms more than 6,000, and then large intracerebral hematomas needing many times operative treatment, 1/5 hydrocephalus, 20%, and then you have aged patients with tortuous vessels, not so well suitable for endovascular surgery. So these are the cases which might have and should have open microsurgery. Now this is from my past, 99. You see this old lady, 75 years old lady, deeply unconscious with very heavy subarachnoid hemorrhage, as a vertebral pica aneurysm. I operated on acutely. If you take that kind of patients, of course, you will have morbidity and mortality in the series, but you may save also lives with your treatment. This is MC aneurysm. They are superficial, the MC aneurysms. They can be picked up like berries, like driving a bicycle. Even my mother could do it. These are usual sayings. Of course, it is not so easy, but they can be done well. And they are special aneurysms, should have open microsurgery, not having stents and coils to treat them. Here are difficult aneurysms, like Dr. Drake called impractical aneurysms. So some of them you might nowadays easily treat with endovascular treatment pipeline, stents, but some aneurysms remain extremely difficult. This is posterior fossa thrombose aneurysm, acting like a tumor. This is the monstrous vertebral basilar aneurysms. Dr. Behnam Rechai Jahromi is doing his PhD on 519 of these aneurysms, and it's soon ready. So they are remain big problem until now, how to treat. And of course, these aneurysms, you need special treatment, large space of basilar bifurcation aneurysm. This is simple aneurysm, MC aneurysm, very simple for open microsurgery, very complicated with endovascular means. So this calcified aneurysm needs, of course, bypass surgery. This giant middle cerebral artery aneurysm was a middle-aged female, Jehovah's Witness, which means that they don't accept blood transfusion. I operated on, resected the aneurysm and clipped the aneurysm, and you see I had intraoperative angiography with C-arm, and these are postoperative pictures. Take a look. Great respect to the aneurysm. I made a good flap to treat the aneurysm, not a small flap, because you have to tailor your approach according to the lesion. And here the case with the intracerebral hematoma, young male, 28, 4 bleedings, same day, Monday, afternoon or evening, both pupils dilated in our emergency room. We made CT and immediately CT angio, and the patient was in 15 to 20 minutes inside the operation room. I took the hematoma out and clipped the ACAM aneurysm. The patient recovered like miracle, could go after some time, some weeks in hospital, could go home, is not able to work as taxi driver, but is able to take care of his children and good father for them. So how is the future? At the moment, 2/3 of the world population has no access to endovascular surgery. We have to remember what we are talking here is first world talk. I think in future we will have biological solutions to treat the aneurysms, and of course there is also prevention to reduce the number of aneurysmal subarachnoid hemorrhage, like in Finland has happened. Reducing of smoking only has reduced the number of ruptured aneurysms, subarachnoid hemorrhage, 50%. So this is important. In China, smoking in males extremely common, and also atherosclerosis in both genders. This increases the number of aneurysms. So then we have recurrences, and this means that you have to have a good follow-up to find the recurrences. They might come after many years. You think the patient is doing well, but then you will have that kind of things. Also in open microsurgery, you might have recurrences, like here. And this is after stenting, big hematoma. This patient I operated on acutely, but couldn't save, he died, young patient. So one more video. So how it looks with the endovascular treatment of middle cerebral artery aneurysm. Here is one video showing an Italian patient 1 year after treatment of her MCA aneurysm. There's a big compaction of the coils and the aneurysm filling, so came for surgery. So this is again under high magnification, opening the Sylvian fissure, injecting water to distend the Sylvian fissure, and then dissecting towards the aneurysm. You will already see the coils, and you see the aneurysm, and hopefully here, after short dissection, I'm pushing a clip on the base of the aneurysm, hoping that it will manage well, but you see the clip will close both M2s, and I try to travel, but both M2s are closed, so we have to open the aneurysm. And after 1 year, it is already more difficult than after recent treatment, because the coils are scarred and part of the aneurysm wall. So now I took the proximal clip out now and begin to take the coils out to have enough space. It looks dangerous if there is enough base left. Now we see the inside of the aneurysm, and then I take curved clips to reconstruct the base and have the flow in M2s. The clips, the coils prevent the clips to close, and then I have to take some of them out, and then add one more clip to have the whole aneurysm closed. And now we make ICG, so the M2s are filling. And this is post-operative DSA done in this special case. So you see that both M2s are filling and the aneurysm is gone. So this is the most important sentence Dr. Drake, PLS, and me wrote in the book on the Basilar aneurysms in 90s. So this is extremely important for your career, life, thinking. If only we could have back again many of those who were lost or badly hurt for a second chance in the operative room with what we have learned. This is very important. You should analyze your cases and make databases of your cases and follow up them and add it to your databases. So the question is coming, is there any hope for the open microsurgery clipping? Yes, I think it is in economy. Why? Because the endovascular surgery is extremely expensive. Also, neurosurgeons are a part of our society. We are very much dependent where the money support is coming, and this is very important. So let's take China as example. It is nearly 5 times bigger than USA population. In roughly 1.5 million populations, there are between 3 to 4 million people carrying unruptured aneurysms. This means in USA close to 1 million. Price of pipeline in China is 220,000 RMB. This is around 70,000 US dollars. Price of a clip is around 300 US dollars. So there's an extremely huge difference in the prices of devices. And of course, if you put the stent, you might need also coils, and these costs are increasing. I think like COVID-19 stopped traveling. I think high costs of endovascular treatment will reduce its use if they don't go down with the prices, and it doesn't seem to be so. So with these high costs, there's no country in the world that can afford those increasing costs if they want to treat all the patients. In the world, there are more important global needs like clean water, food, prophylaxis for many diseases than to push something inside the aneurysms or arteries. Take a look at this picture. This is medical doctor, old famous painting. So we should be like that. Many times we don't know what to do. We are thinking. He has no means to help the sick girl, but he's sitting there thinking and supporting the family. And this is how the neurosurgeon should be. We have difficult diseases to treat. We should support the family surrounding this diseased patient. This was Dr. Drake. He was an excellent neurosurgeon, good medical doctor, but also a good human being. And this is certainly one of the most difficult things to become in the world. Training is once more lifelong. Learn to use your time. Do not spend your life in hospital meetings, in working days. Only very few of these hospital meetings are important. You can fill your whole week with that and then avoid operation room where your main job should be. Aha, are you still clipping aneurysms? Yes, and I am proud of it. We are alive and continue clipping, getting all the time better. And I still think that the clipping is the best and most durable aneurysm treatment with good follow-up and in skilled hands. Perfect clip around the base of those deadly sacs. Very important sentence, nicely formed in English. This is Dante in Italian. You were not made to live like brutes, but to follow virtue and knowledge. And this is neurosurgery. And this is very important. We are lucky, happy to be in this field. So I want to thank the best personnel in the world that has surrounded me through these years. Anesthesists, nurses. This is Hanna-Lena in Helsinki. This is Ping in Zhengzhou, Henan Provincial People's Hospital. Looking at the screen, instruments are flying in the hand without speaking. So, as mentioned, all my videos are free in internet, Hernesniemi 1001, and then our book, Helsinki book, in different languages are free in internet. So just Google my name. So the videos are not available in China, but we are now trying to give them forward to all Chinese neurosurgeons. This is maybe the thing that are lacking numbers. So I thank you very much. Kiitos, seiseni.
Thank you, Juha, very much for this tour de force of summarizing all your thoughts after 40+ career. Appreciate it very much. I'll ask you a couple of questions that came from the audience, maybe before we open it to the panelists. Dr. Marcelo Platas, our good friend from Argentina, wants to ask you, have you always been happy with CTA pre-operatively to tell you how an aneurysm looks, or do you sometimes use DSA?
Since 2000, we used nearly only CT angio. We have been happy with that. Now here in Zhengzhou, they do in every case DSA if there's a smallest suspicion, because they are so experienced in doing DSA. They do 10,000 angios a year. So this is like factory. But I think CT angio is you make CT, you see subarachnoid hemorrhage, you shoot contrast. In 15 minutes, you have beautiful pictures, and you can go immediately to operation room. This was how we did. So I have been happy with them.
Yeah. Very good. I think I'll invite Ziad Haj to share his screen and maybe share one of his cases.
Absolutely. Can you see my screen and can you hear me well?
Yep.
Yes, we see you well.
Professor Hernesniemi, thank you for this very enlightening and outstanding lecture. I'm going to have this daunting task to follow you. Dr. Morkos, thank you so much for inviting me and for putting together this amazing symposium. So I'm just going to show this case of a 64-year-old male vasculopath, known hypertensive, former smoker, quit smoking in 2013, who was on vacation in Jamaica and presented to the emergency room over there with stroke symptoms. He had right facial droop, slurred speech, and altered mental status. When he went to the ER, he felt somewhat uncomfortable. He decided to leave against medical advice before any type of workup was done. And he traveled back to the US and immediately went to an ER at the VA and had workup with a CTA that showed multiple intracranial aneurysms. Now, the plain CT did not show any rupture. There was no blood. They couldn't get an MRI due to a spinal cord stimulator, but there was, based on his symptoms, no sign that it had ruptured, and ultimately all of his symptoms resolved. He was discharged and then referred to my clinic for his aneurysms, and he was neurologically intact, so he did not suffer any sequela from these symptoms, stroke symptoms. So I recommended a cerebral angiogram, and I'm going to show the images. So he had a total of 5 aneurysms, 4 of which were the most interesting, all irregular, ugly-looking aneurysms. Right ICA injection, there's a bilobed, approximately 4 millimeters. I'm going to give in the next couple of slides the exact dimensions. PCOM aneurysm on the right side, and then a choroidal aneurysm as well on that same side. And then on the right vertebral artery injection, a V4 segment aneurysm, and then slightly distal to it, another irregular shaped aneurysm close to pica, but not a true pica origin aneurysm. You could see here the pica origin separate from the actual aneurysm itself. And you could see on the next one, actually, how horrible his vessels are. Substantial amount of intracranial atherosclerotic disease, right vertebral artery injection, so a lot of irregularity. If I show you again the anterior circulation as well, you could see the intracranial atherosclerotic disease here. This shows the left vertebral artery injection, and it's of importance because the left vertebral artery ends in pica, so there's no substantial contribution of the left vertebral artery to the basilar system. So this is what it showed. Those are the important ones. The PCOM bilobed was 4.4 millimeters. The choroidal was 3.1 by 2. Between them, there was a smaller shallow-based ventral ICA aneurysm, and then those are the two vertebral aneurysm on the right side, 3.8 and 5.2. Professor Hernesniemi, would you treat those or would you recommend observation? What would you do in this case, if I may ask?
What I have learned in China, be careful with the patients with atherosclerosis and aneurysms, because first, you cannot use temporary clips, and the aneurysms are very fragile, might have also calcification, even small, on their base. So I would carefully discuss the different means. Of course, when you go inside the artery, then you don't have to take care of the wall of the aneurysm or the artery. So I would discuss with the patient. He has been heavy smoker, so I think the aneurysm have been caused by that. But then this heavy atherosclerosis makes the treatment of these aneurysms more difficult. And how old he was? 60?
Yes, in his 60s.
64. And general condition.
And a former smoker.
Yeah, of course, it is not difficult to treat the PCAM and anterior choroid aneurysm, and the posterior fossa aneurysm need a different approach. Mm-hmm. But you have to discuss with the patient. I think the main concern here, for me, what I have learned is the atherosclerosis. Here in China, the patients have huge atherosclerosis, which is caused by the fatty food, Mao pork, I call it, and then with the very common smoking of the males. Fatty food in both genders, but I cannot give an answer here, but I would be a lot afraid of the atherosclerosis because it makes the regular surgery difficult because you cannot use temporary clips. Absolutely. This is, I say, yeah.
Juha, if I may ask you, with your extensive experience back in Helsinki, suppose this patient had very convincing warning leak before he flew back. Clearly one of the aneurysms leaked. Statistically, looking at these, what's your best guess as to which one may have been the symptomatic aneurysm? Have you what?
I did the right PCAM at the two lobes.
Yeah.
This one, right PCAM might be ruptured one. Yeah. I would suspect. Of course, we then do CT, and but this one I would operate first. Both.
Yeah.
PCAM and choroid.
Can we ask Dr. Binzu? Ben, can you give us your opinion?
This is a good idea.
Yeah.
I don't know if you had the chance to see you were busy translating probably, but.
Yeah. I see the case, yeah.
Do you want me to repeat any of the information?
Heavy atherosclerotic 64-year-old, possibly with a warning leak, with 4 aneurysms, PCOM, anterior choroidal, and Ziad, show him these bottom ones there.
Vertebral artery aneurysm, right vert, V4 segment, and a more distal kind of pica. close to pica, but it's not a true pica aneurysm. Pica origin is here and it's separate from the origin. So there's two, a V4 and a pica. And the vessel is very atherosclerotic right there.
Yeah, I think my treatment, I would clip two aneurysms of pica and anterior coronal aneurysm, and then I will use endovascular treatment for the V4 aneurysms.
Okay.
Do you expect any stent assistance or balloon assistance?
Yes, stent assistant for the V4 aneurysms.
Ziad, you want to ask your co-panelists any?
Absolutely, yes. I don't know if Adib or Kitan are on.
Oh yeah. Maybe Kitan, we start with seniority.
Yeah.
How is this handled in Connecticut?
You know, it's you have such leading experts that are giving opinions. It's hard to really say otherwise. But again, the aneurysms that look the most concerning are the PCOM segment aneurysm and the anterocoroidal segment aneurysm. And I think if there was a warning leak, then I think I would take the patient to surgery to clip those two aneurysms. And I think for the posterior circulation aneurysm, I think I would, like Bing had mentioned, I would consider endovascular treatment, and I would use stent-assisted treatment for the posterior circulation aneurysms.
Adib, and then maybe Bobby Stark after Adib.
Yeah, I agree completely. I think the carotid aneurysms are ugly in appearance, multilobulated. They're right next to each other. It's going to be hard to treat that anterior choroidal with an endovascular approach. I would explore those and clip both of those at the same time. And then you could observe the vertebral artery aneurysm potentially, or you could stent coil that pica. The other one looks pretty small, so it may be hard to treat the smaller one endovascularly. But you may be able to get one or two coils into that more proximal smaller one. But you could also follow those on the vert.
Bobby, endovascular interventions have advanced so much. Is there even any role for microsurgery on a case like this? Can we, I have to ask provoking questions to make it interesting. So what do you think? Seriously.
I get the endovascular questions, I guess, on this one. I mean, I agree.
No, I'm not telling you how to answer. I'm asking, you're an expert.
Yeah, so just taking them separately, the anterocoroidal and the PCOM, we've had cases like that in a very young person where I would favor clipping both of them at the same time. I think that's fairly straightforward. We've had the same case in elderly sick patients, even with smaller, more wide-based aneurysms, and we've been able to successfully coil both at the same time. If it's ruptured or it's leaked, I favor probably surgery. But in a sicker or a more poor grade patient, I would probably favor endovascular. You could coil those. And same thing for the posterior circulation aneurysms. If they're unruptured, I think you could consider following them as Dr. Ablo said, nicely. I would probably favor endovascular treatments for the posterior circulation ones if they're unruptured. I think those could both be treated endovascularly, potentially coils with a balloon or double microcatheter technique or stent-assisted coiling. And then, I don't usually like to place flow diverting stents across the origin of the pica, so I probably wouldn't lean towards that option, but you could still come up with an option where you coil and place a stent and coil the one inferiorly.
Even with an ugly looking vessel like this and a unique vert. So the right vert ends in pica, left vert fills the basilar system.
Yeah, and that's why, I mentioned, I think observation would be very reasonable. I agree. Like those are not easy cases to treat endovascularly, and the risks certainly go up significantly. And then once you need to introduce a stent into those locations, it becomes a lot less exciting. So that's why I also mentioned, for some of these patients, I'd consider trying to do a balloon assisted coiling or a double microcatheter technique and then stent only if I had to. I agree. Proximally, especially below the first aneurysm, it looks quite, the vessel looks quite diseased.
Yeah.
So, but I wouldn't be too excited about clipping these either. You know, you'd have proximal control and distal control, but still the vessel looks particularly bad. I'd want to look at the CTA, and as Dr. Hernesniemi said, see how much calcification there is in the vessel there.
You know, Jacques, I was gonna just for the anterior circulation aneurysms, for the PCOM and the anterior choroidal. I mean, as we're developing sort of our learning curve, you know, the anterior choroidal artery aneurysm is concerning, and I guess the question that comes up in terms of what was pointed out with the extent of calcification, the literature seems to be mixed in terms of preserving the anterior choroidal, in terms of using endovascular means and microsurgical means, and it seems like more the recent series seems to suggest that endovascular treatment would probably preserve the anterior choroidal with a greater frequency. And I don't know what your thoughts on that are, but again, ideally microsurgical clipping, but with the caveat that with this extent of calcification, what are the chances we'll lose the anterior choroidal artery?
Yeah, I mean, I certainly agree with you that what's published in the literature when they've done that meta-analysis, the anterior choroidal had a higher complication rate, certainly than the PCOM. But, you know, you're there for the PCOM, I would still look at it, and, you know, they can be, as you know, thin-walled, and there is duplicated anterior choroidal, and not to include them in the clip and so forth. But, you know, let's hear from Ziad what he did.
Okay, so let me, just to go back, the symptoms were more of the left ICA type symptoms. So I don't think it was a sentinel leak, right facial droop, slurred speech. So I really wasn't convinced that those two aneurysms were symptomatic at the time. And I was very worried about the posterior circulation aneurysms. I was worried about all four of them, but if I had to start with treatment, I would start with treatment of the posterior circulation aneurysms in my mind. So what we ended up doing is I discussed this case at our multidisciplinary neurovascular conference, and the recommendation was to treat all four aneurysms, starting with the vertebral artery aneurysms, then after recovery, treat the ICA aneurysms together. And I opted for surgical option for all four, actually. The reason why I did not choose an endovascular approach is because of what I showed you, Bobby. The left vertebral artery ends in pica, so I was really worried that doing an endovascular approach with a pipeline or coils or balloons or balloon coiling or whatever would possibly compromise the only functional vessel with this amount of atherosclerotic disease. I was really worried. I thought that maybe by doing an open approach, you know, I'd have a better control of flow in the vessel and reversibility. So I could potentially move the clip or do something or even abort if need be. So I don't know, I felt more comfortable doing it endovascularly. So I decided to proceed with a far lateral transcondylar approach on the right side. I planned for intraoperative angiography and the use monitoring with SSCP, MEP, and then I monitored cranial nerves 9, 10, 11, and 12. Sorry, I don't have a video. I didn't have time to put one together, but basically standard hockey stick incision with the standard positioning of the patient and pins, exposure. I drilled the condyle, and I'll show you at the end the CAT scan of how much of the condyle was taken. Exposed the V3 segment of the vertebral artery on the right side, mobilized it. So I knew that if I could not get intracranial vertebral artery control, proximal control, because of calcification, I'd have better luck extracranially with the vert being exposed right there, because I could feel that the vertebral artery extracranially was compressible. Cut the dentate ligament to mobilize the upper cervical cord a little bit, get me a little bit more space. The proximal V4 segment proximal to the first aneurysm was very, very calcified. I mean, very, very calcified. You could see that through the vessel. The first aneurysm dome was seen, highly irregular. All of the 12 rootlets were crossing over it and stuck to the dome. And then the distal dome of the aneurysm was also kind of stuck and digging into the medulla. So I had to dissect those very carefully and kind of stop right there because I did not want to clip this one first. Then I identified the pica origin, which again, based on what we knew from the angiogram, was separate from the more distal aneurysm. The distal one was also very irregular. It had rootlets of the 10th cranial nerve kind of adherent to the dome. Those had to be dissected very carefully, very fragile nerves. Kept stimulating. I had the option of stimulating those nerves, and I did, and they remained intact. Then I decided to clip the distal aneurysm first because then the clip blade would be and the hub would be away from me, obviously. So I used a 10 millimeter straight bayoneted clip, and after I clipped it, I saw that there was a remnant at the base. And to follow with the concerns that Professor Hernesniemi had and just mentioned, I thought I'd try a temporary clip in order to deflate that aneurysm and be able to push the clip down and get that remnant at the base, and I was absolutely unable to. My clip did this and stayed exactly like that, so the vessel did not budge. So I literally had to move my clip and replace it without temporary clipping, and thankfully I was able to. So I was able to readjust it, and I had no remnant. I made sure that the 10 rootlets were not inside the clip blades, especially at the very distal end. And as you can imagine, despite my far lateral transcondylar approach, I had difficulty looking at the very distal side of the dome and making sure that the clips were not involving any of the rootlets or any perforators. Then I came down and I tackled the proximal aneurysm. I used a 45 degrees 5 millimeter fenestrated clip. Again, this one had to be repositioned, and I had no problem getting full obliteration of the aneurysm. Again, important move to inspect the rootlets of the hypoglossal nerve to make sure that they were not in the clip blade. And then I did intra-op angiography. I had, before positioning the patient, while the patient was still supine, I just placed a long sheath, 45 centimeter sheath, that I pretty much turn around and I suture to the buttock so that I have access to it in a lateral 3/4 prone position. So the angiogram was done in that position with the radiolucent Mayfield. And you can see that both aneurysms are completely obliterated with full patency of the pica right here. And again, the very ugly looking vessel. This is the postoperative CT scan in bone window, just to show you the extent of the exposure. So I took half of the posterior arch of C1 in order to mobilize the vert, bring it down, find the condylar, atlas condyle junction, and then drill the condyle. Not a lot, just enough to get me there. And then you can see my first clip, and distally my second clip right here. The patient woke up intact, no lower cranial nerve deficits. He did well, had a slightly slower recovery. I think he had a pneumonia during his hospital stay, but otherwise was discharged and did well. He's currently awaiting treatment of his, this is relatively recent, so he's waiting to have his right IC aneurysms treated. I think that's it. This one.
Good job, Ziad. Yeah, very nice.
Thank you.
Excellent. I think just for the sake of time, we'll go to Adib. If you could stop sharing your slides.
Yes, absolutely.
Any comments from anybody on the treatment of Ziad?
What a fight.
Yeah, it was.
Are my slides showing up?
Yeah, very well, Adib.
Okay, great. You can hear me okay?
Yes.
So thanks so much for the opportunity, Dr. Morkos. Really appreciate the invitation. Professor Hernesniemi, thank you for your lecture. Always inspiring. I remember you spoke to us in Phoenix in 2008 when I was a junior resident. I was inspired then, still inspired today, so thank you. Really enjoyed that. So I'm going to talk, let's see.
Click on the actual present. Yeah.
Yeah, got it. No disclosures here. These are all my cases. Obviously, as Professor Hernesniemi said, always important to recognize that we stand on the shoulder of giants and those who trained us. So always important to recognize your mentors and also your team. Neurosurgery is a team sport, and we work with a big team. This is the case. This patient presented from an outside hospital, sudden onset, worst headache of life, nausea and vomiting. She had a known aneurysm that had not been treated, had been followed, and no one had ever offered it an angiogram because of this genetic mutation that she had. They were worried that she had a vasculopathy that would make it dangerous to do diagnostic angiography. And so she presented to our institution with ptosis and ophthalmoplegia, but otherwise a non-focal exam. And this is the finding, subarachnoid hemorrhage. And we can see a mass, obviously. And then the CTA, hopefully this comes through, but we can see it here. So she's got multiple aneurysms, but the left carotid aneurysm is the one that we're worried about. And we can see that she only has one A1, and this aneurysm starts in the petrous segment and is partially thrombosed, obviously giant, and she's got that right MCA, which we don't think ruptured. So here it is, partial thrombosis. This had been growing over the years. Now it's ruptured. She had never been offered treatment. She's got this other aneurysm. And then again, she has a left A1 aneurysm as well, and no A1 on the other side. So both A2s and this whole hemisphere fell from that carotid. And here we can see the sagittal. So it starts very low, and most of that aneurysm is cavernous, but it has blown through the distal ring, and so that's why we have the subarachnoid hemorrhage. So I'll stop there, and Professor Hernesniemi, I'd love to hear your comments.
I see this is very complex case. Complex case. It is not straightforward case, like many are saying. But I think this is a case you need a bypass to treat the aneurysm, to trap the aneurysm. Based on this, what I see. Fresh subarachnoid hemorrhage from a giant aneurysm, so which you can, I think you cannot clip, and the patient has some angiopathy also. Also, I think this is a bypass case to trap the aneurysm.
I have been hesitant usually to do bypasses in the acute setting of subarachnoid hemorrhage. If I can afford to wait, I usually wait and then I do the bypass. What do you have a different opinion on the timing of the bypass?
My experience in bypasses is very, very low, 100 plus cases, but I cannot say. We should ask Subin. He has done more than 7,000 bypasses. So what is your opinion, Subin?
Yeah. Actually, if it's a ruptured aneurysm, we still can do the emergent bypass surgery. It's more difficult, but we still can do that.
Yeah, no, I'm not worried about the technical aspects of it. I worry about vasospasm, and I've had a couple of patients.
Yes. You know, sometimes we also wait. Yeah.
Right. Shubin, would you do this case of Adib endovascularly with the flow diverter, or would you do it open, or how would you handle this case?
This case definitely needs the bypass surgery, because if you use a pipeline, you need to use antiplatelet treatment. It's very dangerous for rebleeding, rehemorrhage.
Okay. Adib, back to you. You're in charge.
Yeah, so those were our thoughts exactly. This is a very long aneurysm. We didn't think we could get a flow diverter across this. Didn't really have a good clipping option to go into the cavernous sinus. And I did worry about vasospasm, but in terms of the progression, so our subarachnoid hemorrhage algorithm for aneurysms that have ruptured, start with coiling. If it can't be done, consider clipping. And if that can't be done, then I go to bypass. So that was the progression here. I think this aneurysm fails options 1 and 2, so you have to go to bypass, as the professors mentioned. So in terms of what to use here, we're considering high flow and low flow. Radial artery, for the same reasons that Dr. Morkos mentioned, risk of vasospasm. And, if the patient goes into spasm, may not provide enough flow. The one question, I guess, would be the most provocative about this case is to trap or not to trap. So I don't know if we have time for questions, but that was the most provocative part of this.
Yeah, of course. You ask whatever questions you want, Adib, of whoever you want.
Does anyone want to have it, or anyone want to comment on what the potential is for trapping or not trapping, just for the viewers? I guess it's one technical nuance here to consider.
As opposed to a Hunterian ligation, you mean?
Yeah, exactly. So whether to go proximal or proximal and distal.
Yeah.
I'm worried about a very long column of clot with that serpentine segment and the thrombus. So if there is room for a distal trapping clip, that's what I would favor.
Yeah, I mean, we considered that, and I'll just show the diagram. This was kind of how I mapped this case out. I wanted to promote as much flow as we could to the anterior choroidal and to the PCOM on that side. And, I knew this aneurysm came fairly close to the origin of the ophthalmic. And so I wanted to start with less and then do more if needed. I didn't want to do a clinoidectomy and take all this down in the acute setting. And plus we need to create flow through the saphenous, down the M2, down the M1, out this M2, and then also fill both hemispheres. So I didn't want to trap it unless we were absolutely forced to. So it's, a little bit of a, not a gamble here, but I felt that if we could just proximally occlude this, it would make the surgery a lot more simple for this patient without having to dissect down and get all of this out. And then we could always come back if we needed to. And fortunately, that did the trick. Just one clip at the ICA origin in the neck. And so this is what we did. We used the saphenous. I got vascular surgery to harvest the saphenous, 30 centimeter segment. We went to the common, as we discussed. She was swollen, but fortunately the fissure opened up nicely. Her M2 really rolled out superficially towards the opening of the fissure towards the surface, and then just did a bypass to the saphenous here. About an 8 millimeter arteriotomy, and then interrupted suture on both sides. And then once that's in place, we go down to the neck and just bypass to the carotid.
For the audience, Adib, could you mention what's going through your mind regarding choice of the proximal anastomosis? You have a choice between common, internal, or external. What goes through your mind?
Yeah, absolutely. So with the choice that we had, I chose the common because I found it's a little bit easier to access, typically for me, and then we can just put a clip on the internal, and I like to do the end to side down in the neck rather than end to end to the internal. You can use the internal, but it's a little bit more distal, so you have to dissect a little bit more superiorly as you would for a CEA. And I find the common tends to be a really nice donor. And then we just put a clip across the origin of the internal. And then the other thing is, if we clamp across the common, we have the potential for some retrograde flow from the external up the internal to just help out with a little bit of ischemia time or collateral flow, rather than putting the clip on the internal. So that was why I went to the common here, and we had the length.
Yeah, I agree with you in general. I just was worried that there is no A1 on the other side. And all the points you mentioned, that's what I usually use, common. But in this case, I probably would have used external end to side, though, to avoid completely no flow arrest into that, semi-isolated carotid, I guess.
Right. No, that's a great point. But also, you would have gotten the same flow through the external most likely after you occlude the internal or at the origin. But I guess I was worried about getting as much flow as we could to that hemisphere and the right ACA. But yeah, I think external would have been fine. And so here's our flow Doppler, and we verify that we've got flow through the saphenous, 157 mLs per minute. So I did not do an intraop angiogram, And nobody wanted to do an angiogram on this particular case in that setting until we knew more about her vasculopathy. So we just did everything off of CTA. And so this is what we ended up with. We can see the saphenous, we can see it anastomosed here to the M2, and then we get flow all the way across M1, IC8 terminus, and then we can see the retrograde flow. Here's a video of that. So we can see the retrograde flow, and then you can see a difference in the contrast. So this was post-op day 0. You see less intensity of the contrast here. So this is already starting to thrombose, and then I'll show you, this is post-op day 3, where the contrast in the aneurysm has gone away. But there's the junction of aneurysm, and then at the location of the ophthalmic is really where this this transition from normal to abnormal. I mean, it's all abnormal.
Yeah. Go ahead. Sorry.
No, that was it. I mean, she wasn't perfect. She did have some spasm and some hemiparesis, but she recovered eventually. And I'll show you the MRI and the CT perfusions. You can see the CT perfusion post-op day 3, but then we have some watershed infarcts post-op day 7. And then here's her 6-month CT. So you don't get away completely free here. I think she definitely has some paucity of speech, but can say short sentences. And her hemiparesis is improved, but she still has a pretty significant limitation in right thumb movement, but is now anti-gravity in the right upper extremity and can walk with a walker.
Do you think you could have avoided any infarcts by putting a distal clip? Or do you think those are vasospasm related?
That's a great question. You know, I'm not sure. I think they're probably from vasospasm, but the other thing is hemodynamics. Is that saphenous vein graft providing enough flow for that entire left hemisphere? I thought it was, but I'm sorry. How would the distal clip? You think the strokes maybe from emboli?
Thrombus in the aneurysm, because that's what you want to happen ultimately, is for the aneurysm to thrombose. Somehow, even though the flow is coming the opposite way, somehow it can happen.
I see. It's certainly possible. Yeah, I thought the flow would be going down the ICA
absolutely
supraclinoid segment to.
Sometimes it finds its way. I've had.
Sure. Yeah, and we put her on aspirin. And the other thing I didn't mention is I give 5,000 of heparin during the high flow cases. You know, when we use interposition. But yeah, that's a great point.
Yeah, and the other thing too is, you know, the ophthalmic, again, we're lucky that no thrombus showered down the ophthalmic at that junction, you know, at the top of that column. I've had a couple of cases where, you know, you hope the flow will go cleanly to the last branch. And I mean, all you need is a millimeter of imperfection, and then you shower emboli and get blindness in the retina.
Couple of things I wanted to add, Adib, about your point of how would you know how much flow you needed, whether it was enough or not, to follow in the footsteps of my great mentor, Professor Charbel. I think if you use NOVA, that it allows you to measure how much flow you need to replace, and then if you have the opportunity to do intraoperative measurements, you can calculate that deficit that you're going to need, and then you can decide. But I mean, honestly, I don't see any higher carrier than a saphenous vein.
I mean, that's a phenomenal point. Absolutely. We don't have NOVA. And my hope was that all the flow that she would have had going up the internal would just find its way to the graft. But I mean, you can't know for sure without NOVA, for sure.
Thanks, Adib. Great case. If you could stop sharing your slides. And Ketan.
Yes.
Please share a Connecticut case for us, with us.
Okay. Let's see. So again, Professor Hernesniemi, Jacques, thank you for allowing me to be on this panel with both of you. I learn an amazing amount of stuff every time I interact with you, read about all of your work. Bin, Ziad, Adib, I mean, those are some amazing cases, and Bin, it's great getting your input on these cases also. So the case I was going to share is this 47-year-old right-handed patient who was involved in a very high-speed motor vehicle accident. She suffered extensive orthopedic, pulmonary, and abdominal injury. And amazingly, through all of this, her neurological examination was non-focal. As part of the trauma workup, she got initial head CT. And again, for the extent of the body injuries that she had, her intracranial injuries were very limited. An excellent neurological exam. She had some trace subarachnoid hemorrhage and a subdural hematoma on initial CT. Because of the subarachnoid hemorrhage, even though it was trace, because it was given the mechanism of injury, we got a CTA initially, thinking, well, maybe there might be some injuries there, and there were no vascular lesions identified on CTA. So at this point, she's making her recovery, and normally for these sorts of patients, I've been getting surveillance imaging a few weeks down the road, just given the mechanism. So at 4 weeks up, again, just given the mechanism of her injury, get a surveillance CT angiogram. And now on the surveillance CT angiogram, there's a new aneurysm present on the distal anterior cerebral artery, specifically one of the paracentral branches, and a catheter angiogram was performed. And in terms of the angiograms and the surgeries that I do, like most of us, I do them in a hybrid room where once you go into the room, the intent is when you come out of the room, the aneurysm is treated either microsurgically or through endovascular means. And this is an oblique view, and this is a new aneurysm. 4 weeks ago, this aneurysm wasn't there, and now we have this aneurysm, presumed dissecting aneurysm, and just open up to. Yes.
Ketan, can we ask Bobby, my partner, Bobby Stark, to analyze this and give us his opinion?
Yeah, it's, that's a tough one. If it would definitely, sometimes these could be missed on a CTA, but if it wasn't there and you have a new aneurysm, that's certainly highly concerning. To me, we're fairly zoomed out, but even on this view, it looks like there's some narrowing of the inflow and the outflow. So I agree, in the setting of trauma, I'd be very worried about a dissecting aneurysm. Generally speaking, I think we're a lot more conservative treating these from an endovascular approach. And a lot of times we favor surgery. From an endovascular approach, you could consider stent coil. I don't think you'd be able to primary coil this alone, because I think it's probably more like a pseudoaneurysm or dissecting aneurysm. But I would probably favor an open surgical approach, and I would, potentially be ready to do even a distal bypass and trapping that segment, because I'm not sure that you're going to be able to clip that directly and still preserve some sort of neck if it's really a traumatic aneurysm. Do you have some magged up images that show that it really has a disease portion on the inflow and the outflow?
Yeah, Bobby, I don't have a magged up image, but you could just this image shows that clearly there's the proximal portion is diseased, and again, it looks like it was probably with this the anterior cerebral artery was tethered and just had a lot of shear injuries. So again, I think there on the mag views, I apologize, I don't have it's consistent with a dissecting aneurysm. And again, the concern here is even though this goes to one of the paracentral branches, even this is a paracentral branch, and it would go into, even though we know that there's no such thing as non-eloquent cortex, this is an area that potentially, if you close off this artery, you may be able to get away with it. But in terms of collateral flow, when you do the vertebral injection, which I don't have, from the terminal portions of the occipital trunk, there's really very minimal collateral into this flow from the posterior, like pericallosal artery, and so. I'll throw it out to Professor Hernesniemi, Jacques, and the rest of the panel. Yeah. In terms of trying to keep this vessel open, because again, I thought, it's a relatively young patient. I want to find a way to keep the vessel open with the endovascular means, like Bobby's pointed out, with the stents, and I mean, especially with the stents in a small vessel like this, I think that'd be probably it's very far out, and you'd probably consider the vessel. You're probably going to lose the vessel, and then with microsurgery, what are the chances that we're going to be able to preserve this vessel?
Well, I have my opinion, but I'll ask Juha to go first. Juha, suppose then this is traumatic aneurysm at the edge of the folks. You treat microsurgically. What's your plan?
I would operate on it. I think you think Falks is coming that down. This is
I mean,
the
I don't know. I'm trying to think. It's dice.
yeah. But I'm suspecting this is a regular aneurysm. I would go with surgery for that because Falks is not coming down to the corpus callosum. So why it should be a traumatic aneurysm?
Well, he said it wasn't there at the time of the trauma, correct, Ketan?
Yeah, 4 weeks ago, it wasn't there, Professor.
It was not there 4 weeks ago, and she.
You made DSA also then?
Did a CT angiogram 4 weeks ago, and then a repeat CT angiogram, and it showed up, and both were very good quality, and it showed up on the repeat CT angiogram. And then
anyhow, I would go with open microsurgery there to explore the site, to clip the aneurysm.
And if it's not clippable, if it's a dissection, I guess you consider reconstruction, no? I mean, one option, I can't use my pointer, but Ketan, the vessel just below it, you can use a nice side to side, trap that thing and side to side, and
Okay. So again, just going into the hybrid room, thinking of those options. I did a super selective catheter angiogram, and again, this is what it looks like on the angiogram. And I think in terms of my thinking process, trying to preserve this vessel. Not sure that I would be able to, even if I attempted it, keep the vessel. I'd probably lose both vessels if I tried to do a bypass on this. I'd lose both vessels for sure. I thought, well, there is an opening here. It's probably too small for a stent, but it seemed like it was good enough to get a microcatheter through. And so I get my microcatheter through this opening, and while the microcatheter is in there, it's occlusive, and get one coil into the dome of the aneurysm, and this is the immediate post-op result. I don't have I followed this lady for 4 years now, and again, what's amazing is even though there was it looked like it must have been a very small proximal flap resulting in this dissecting aneurysm. The vessel has maintained its patency out at 4 years, and we've been following with MRAs. So again, it was just these aneurysms have always dissecting aneurysms, at least for me, have always been very, very tricky, whether they be in the anterior circulation or posterior circulation, or I mean, in this location, I haven't dealt with a lot of them, and this was one of the first ones that I dealt with. And in this situation, we were able to preserve the vessel using the endovascular means. But that's what I have on this one.
Ketan, I'll read to you one comment from Edgar Natal, a superb cerebrovascular. I'm just going to read his comment he put here in the chat, in the QA. Hello, Edgar. Thank you for joining us here. This case of distal AC aneurysm seems to arise from an anatomic variant of the ACOM complex, maybe a median artery of the corpus callosum, because they seem to be independent arteries, the pericallosal and the callosomarginal. I think the best option is microsurgery. That was his comment. But well, I think you got lucky here that it didn't. I mean, that simple endovascular maneuver resulted in a permanent cure, but could have gone the other way too. But good job. Any comments from the panelists? Anybody?
I was going to opt for a microsurgical approach. Honestly, I'd be worried with a stent because of that. I think it's probably vasospasm after trauma. A traumatic aneurysm with vasospasm probably at the branches going in and out of the aneurysm. So my first thought was microsurgery, especially that I'd be worried about putting the patient on blood thinners with a stent in the setting of a subdural. I don't know if it had resolved by then or not, but she had subdural and subarachnoid. So, and I had the same thoughts as you, Jacques, that in the event that the aneurysm is friable, there's no neck, then there's the other vessel next to it you can bypass too. Knowing the risk of losing both vessels, as Kitan said.
Adib, how would you have managed the case?
Yeah, I probably would have personally gone open and tried to clip reconstruct, and you have a nice donor vessel there next to it in case you can't. But I mean, it's hard to argue with that picture. That's a beautiful result. Very nicely done.
Well, of course, Kitan hasn't shown us the other 10 cases that have failed. He only chose the one that has worked. But that's Kitan for you. No, I'm joking.
Yeah, you know, Professor Marcos, this is the only dissecting aneurysm I have for the ACA. So, so right now I'm batting 100% on these. Juha,
there is a question from the Dr. Marcelo Platas again. He said, would you recommend using navigation for ACA aneurysms? Perhaps not in your hands. You've done so many, but people who may not have done so many ACAs and honestly can probably get lost to know which part of the interhemispheric fissure to go to. Is that something you'd recommend? Intra-op navigation?
It's very good to use navigator if you don't have big experience to go there.
Yeah.
Because you don't have any landmark. So navigation is very good, helpful.
Shubin, do you have any comments in general? Because it's now 9 o'clock and I'd like to, we've answered all the questions posed to us. Any questions, Shubin, any panelists, anybody wants to ask somebody else a question before I send you all back to your beds or to your work? No? Well,
no question.
May I say something?
Please.
May I say something?
Yes,
okay, we have to thank Shubin. He added 2,000 Chinese neurosurgeons.
I know, I was about to thank him. Yes, I just wanted to.
Yeah, but 2,000 is the number.
Unbelievable. Shubin, we are extremely grateful for what you've done, waking up early, helping us advertise this, and helping everybody listen to the grand master of cerebrovascular neurosurgery and a friend of so many of us. Juha, you are a living legend. Legend doesn't mean your work stops, you are. And please continue doing what you're doing, teaching and inspiring everybody. To my friends on the panel, thank you so much for showing up. To the audience, thank you, and I bid you goodbye. Thank you.
Thank you very much.
That was an amazing symposium. Thank you so much.
Thanks so much. Thank you, everyone.